Hello, my name's Anna Britton. I'm a clinical oncologist based in the UK, working in Brighton, and I've been very kindly asked to give a talk on the role of radiotherapy in lung cancer treatment. My declarations of interest: I work part-time in the medical affairs department of Elekta, which is a medical device company involved in manufacturing radiotherapy equipment. So lung cancer, all of you know about lung cancer, we wouldn't be attending this conference otherwise. It's the second most common cancer in men and women in Europe. But if you look globally, it's the most common in men, and it's the third commonest in women. In Europe, however, it's got the highest mortality rate out of all the cancers, which is pretty shocking. It's one of the easiest to avoid. The European Beating Cancer Plan quoted that 9 out of 10 lung cancers could be avoided if we just took measures to prevent it. And obviously the prevention measures would be smoking cessation primarily. It's one of the hardest cancers to treat because biologically it's aggressive compared to perhaps other cancers, but also obviously it's within an organ that moves. So there's that motion aspect, which makes it difficult to target with radiotherapy. Now, the European Commission did make a position statement on lung cancer screening back in 2017, strongly advocating screening. But as we are today, 2021, there is still no established screening program within a lot of European Commission member states. There's been quite a lot of pilot studies in Germany, France, and the UK, for example, which have demonstrated that a screening program for high-risk patients would be useful, would save lives, basically. So why the bad statistics? Why is cancer doing so bad, lung cancer doing so badly? When we look, for example, at the range and the number of drug therapies available, particularly this bit of information from the Lung Cancer Research Foundation, looking at the FDA approval for lung cancer treatments, it's quite remarkable. And even in my own practice, where I prescribe drug therapies, I have such a range of options nowadays, which I didn't even have 5 years ago. And they're not cheap, obviously, so they're costing healthcare systems quite a bit of money. And the evidence to support their efficacy is not always very, or doesn't demonstrate very large survival advantages. And the same sort of similar data on the Fortune Business Insight, we look at expenditure on lung cancer therapeutics, and the forecast for 2026 is it will practically have quadrupled since 2018. So a huge amount of money is being poured into therapeutics, big pharma, drug therapies, basically. And despite that, our statistics are not great. So the keys to improvement we already mentioned. Obviously, prevention is always better than cure. So trying to prevent this cancer, smoking cessation, which there's so much data out there, so much strong evidence suggesting, supporting the role of smoking cessation. Obviously, there are other aspects to lung cancer etiology. For example, the environmental factors, which the European Commission is also taking a stronger stance on. But preventing the smoking is probably the most important. And then obviously early detection, we mentioned already this lung screening, which would save a considerable number of lives had we got it implemented for obviously the high-risk population to start off with, and then eventually, who knows, maybe more people would become eligible. And this obviously makes me think about COVID and the impact on COVID on lung and lung tissue biology. Are we going to see more cases of lung cancer due to damage from COVID infections? That's something still to be obviously looked at. And then unfortunately, for those who are sadly diagnosed with lung cancer, the best outcome would be if they can receive a personalized cancer care treatment, obviously. So an individual pathway, a very singular approach, and a unique management tailored to them and to their cancer. So the individual pathway is similar in most countries, I would say. It always starts off with some diagnostic tests, which usually involve some images, X-rays, CT scans, PET scans. But obviously within that, beyond that, the biopsy is actually quite critical. Biopsies now are also processed for what we call molecular profiling. We do a panel of about 5 or 6 different molecular markers in the UK. That profile will get bigger and bigger as more targeted therapies get developed for those particular markers. So it's driven by pharma and the development of drug therapeutics as well. And then the MDT, or multidisciplinary meeting, is critical for all patients, where you discuss patient cases within a panel of, say, surgeons and respiratory experts and obviously oncologists, and decide, first of all, what the intent of treatment is. Is it going to be to cure or to palliate? Because obviously these are two very different paradigms. And then the best way forward, the strategizing starts. And that's become extremely complicated because of all these therapy options, these drug therapy options. So navigating the strategy and getting to the optimum strategy for that individual patient is sometimes quite difficult. And then obviously there's a meeting with the patient, deciding with the patient what their wishes are, assessing their fitness for undergoing all these difficult treatments. And then obviously coming to an agreement, a contract, which essentially means signing consent forms, informed consent forms. And then treatments, which take a variety of combinations, some extremely difficult. Obviously, if you think of the most complicated treatment, would involve maybe some chemotherapy plus radiotherapy followed by surgery, potentially followed by more therapy. And then you're looking at sort of piling on one treatment on top of another in an individual who's maybe not the fittest and certainly won't be the fittest going through all the treatment and ending up at the other end of it. And then follow-up, which is just as important. There's no point going through all of this and not having a very rigorous follow-up system where you keep track of that patient, the effects of the treatment, so what we call the long-term effects, and then obviously for any recurrences, watching out for relapses and recurrences with scans regularly. So the singular approach, by that I mean it's taking the tumor characteristics. We talked about the histology, the biopsy, the molecular profile, obviously the size, the stage, the TNM stage of the tumor, the subtype, small cell, non-small cell, adeno, squam, and then feeding that into sort of an algorithm alongside the patient characteristics. So how fit they are, their age, their premorbid condition, their other health conditions. Do they have lung conditions like COPD or asthma? Have they got a cardiac condition? What is their lung function? So you put it to the test. What is their heart function? Again, assess their heart function. And you also add to this the current clinical evidence, the best practice guidelines, because that will change regularly as the evidence comes up. Current clinical evidence is constantly accrued and analyzed and appraised, and it will change the best practice of the day. And you come out at the end of this analysis and appraisal with a customized, possibly multimodality treatment. By multimodality, I mean it might involve chemotherapy plus radiotherapy plus surgery plus biological agents, immunotherapy, for example. So it's very, very individualized. And you essentially, the more precise, the more individualized you create that strategy, the better the outcome. There is no doubt. But because of the number of options now becoming available, that strategizing is becoming very complicated as well. It's not to say that you can't go back. You decide on a particular strategy, you can reverse and go back to another strategy. In fact, it's not unheard of that you might start down a palliative route and convert to a radical route, or similarly the other way around. Start down on a curative pathway, but for whatever reason, some information will change the paradigm to a palliative course. So it is not fixed in stone, and it's important actually to keep abreast with what's happening with the patient. So the therapeutic index basically is the balance between the toxic effects of these treatments, which are not easy, even in the palliative context, with the therapeutic effect, the cure rate or the control rate, whatever your target, your aim is. So best practices I've mentioned already. So we have many guidelines. It's not something we can't access at all. We have a range of therapies that we mentioned. So I divide it in my head in two groups: the local therapies, which are not obviously all over body therapy. So we've got all the surgeries, the radiotherapies, and I put multiple because there are different types of surgeries and different types of radiotherapies. And same with non-radiotherapy sort of targeted therapies. These thermal ablations, for example, radiofrequency ablation, or microwave ablation, or cryoablation. And then we've even got non-thermal ablations, though I've never had to use one for any of my patients. I think that's quite low down on the clinical evidence. And then the systemic therapies, which are drug therapies, and by that I mean they go all around your body. Chemotherapy is obviously a bit like napalm, just kills everything in your body, not very precise, not very clean. And then the biological targeted therapy is much more clean, like a Scud missile, a lot cleaner in terms of effect and side effects. Then the immunotherapies, a lot of talk about them, even looking at immunotherapies after surgery or after chemoradiotherapy. Immunotherapy is combined with chemotherapy, immunotherapy combined with radiotherapy, all sorts of data, clinical evidence coming out about that. And then the investigational therapy. So always think about clinical trials for patients as well. So radiotherapy's contribution to survival, it's there black on white. We know that patients who have radiotherapy as part of their pathway, whether that's at the beginning, the middle, the end of their pathway, whether it's to control, as in to palliate, or whether it's to cure, we know it makes a difference to their survival. It prolongs their survival. And compared to other treatment groups, and in this case, this paper I found was just looking at non-small cell lung cancer, the patients treated with radiotherapy showed a greater median survival and overall survival compared to those without. And now that data does come from SEER data from 1999 to 2008. It mostly covered what we call 3D conformal radiotherapy, which is by nowadays standards maybe a little bit old in terms of technology. But there probably were some patients treated with more advanced techniques like IMRT, you'll have heard, intensity modulated radiotherapy, or SABR, even stereotactic ablative radiotherapy. Obviously, the contribution, I suspect the contribution to survival will be even greater if we look at data just involving those advanced techniques. The advanced techniques are better because they obviously deliver radiotherapy to in a more precise fashion, and you can therefore increase the dose. So it's completely convincing data. Oops. So another slide on radiotherapy's contribution to survival, and this is looking more at not just the curative setting, but also what we call the oligometastatic setting. So oligometastases, patients with oligometastatic disease have limited metastatic disease. They haven't got widespread disease. They're still potentially curable. So it's a fairly new group of patients that we are trying now to be more aggressive with and try and cure, but it does entail quite a bit more treatment, obviously. And this particular paper, which is very good, in 2019, showed that the SABR, stereotactic ablative radiotherapy, to the primary, what we call the primary site, the mothership, think of it that way, and the metastatic sites, also improves median progression-free survival and overall survival. So a lot of data mounting up and accumulating, proving to us that radiotherapy, in this form and in other forms, does help patients to survive longer. But the balancing act is obviously with the long-term effects of radiotherapy, because there is nothing, unfortunately, no cancer treatment that doesn't leave you with some long-term effect. It's just the magnitude of that long-term effect that we need to balance out and control. So personalized radiotherapy, that's available to most of us in the sort of lucky countries. It's a lengthy pathway. It has to be careful. It has to be meticulous. It involves a lot of steps, a lot of people, a lot of technology, software, hardware, and so it's not readily available to everyone. It comes at a price, obviously. So patient immobilization, so that means lung cancer, because of where it is within an organ that moves, you have to be able to predict where the target, the lung cancer, is going to be. So we need a lot of technological support to keep the patient stable. We need imaging to watch that tumor as it moves, and it doesn't move in a very organized fashion. It's quite irregular in its movement. So we have something called a planning scan, where we take images of the target, the cancer, and then you have other technologies we can fuse with PET scans, and then the business of actually drawing around where we want the radiation to go. So the delineation, we call it, and where we don't want it to go. So the structures around, the normal structures, the heart, the good lung, the chest, the blood vessels, all that has to also be taken into account, because we don't want to damage those. And then the dosimetry means sort of the dose calculation. So we're looking at very carefully depositing radiation dose where we want it to go and not elsewhere. And the planned evaluation is the part where the radiation oncologist sits down and decides what is the best plan out of the choice that he or she has got. And then it's all systems go and treat. So radiotherapy is becoming more fast, more accurate, as I said, with the advanced techniques. It's image guided now with CT, but also MR. And also ultrasound. There are other ways of image guiding. We are looking at what we are now treating with smaller courses, shorter courses. Gone are the days where people used to spend 6.5 weeks having daily radiotherapy Monday to Friday. That's quite rare nowadays. But we're trying to sort of shorten the courses, not just for the convenience of everyone, but because radiobiologically it makes sense. And that's actually important to remember. We're not doing it just for convenience. So hypofractionation means giving shorter courses, but each individual treatment delivered is a bigger dose. So these are the stereotactic body radiotherapy, stereotactic radiosurgery, stereotactic ablative radiotherapy, all different terms for different parts of the body. So I'll go back. We need AI, artificial intelligence, automation. We need smart oncology information systems. We need tools that will draw around these targets quickly and accurately. And we need very, very up-to-date treatment planning software to create radiotherapy plans which need minimal tweaking or editing in order to speed it up and to get patients treated rapidly, because obviously the clock is ticking. We cannot afford to wait too long. So the other aspect of sort of radiotherapy is you can adapt it. You can adapt it obviously to the movement. We mentioned already image guidance. So the target's moving within a lung. You can adapt it to how the target, the tumor, responds to treatment. In the course of radiotherapy, that tumor might start shrinking really, really nicely, in which case you need to adapt your radiotherapy to the current size. So that's called adaptive radiotherapy. You're adapting it in order to, first of all, make it safer and also more effective, because then you're not giving unnecessary radiation to all the structures around the tumor. It does obviously add work because you're having to basically loop the loop. You're going back to the delineation step of the process, redoing the calculation of dosimetry, redoing the plan evaluation, and all the while you're not stopping the treatment. So it has to happen on the fly, so to speak. We talk about online and offline adaptation. That's the best, the holy grail of radiotherapy, to do adaptive radiotherapy for everyone, regardless of what they're having their radiotherapy for. And it can be used repeatedly. So that's something also that's not really talked about much. Radiotherapy can be repeated. For example, someone may have a curative type of lung cancer. They have radical or curative intent radiotherapy, but say 5 years later, they relapse with either the same cancer or a different cancer, but it's sadly not curable, it's metastatic. You then can re-explore radiotherapy. It's not a one-off. Re-irradiation has to be very carefully planned, obviously. You can't just do it without any careful preparation because it's damaging if you're not careful. But it is absolutely possible and safe. And it can be done both in the curative and the palliative setting. So that concludes my talk. Thank you very much, and I look forward to the questions. Thank you.